The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/GKC860. Downloadable slides and practice aids are also available.
Hello and welcome to our webcast at the Therapeutic Crossroads for Renal Cell Cancer, investigating the current application, controversies, and the future use of immunotherapy and targeted agents. Tonight, we will explore the latest update in the therapeutic options for advanced kidney cancer and have case discussions to explore strategies for choosing the optimal and effective treatment plans for our patients. I'm Dr. Tony Choueiri from the Dana-Farber Cancer Institute in Boston, and I'm pleased to welcome my colleagues, Dr. David McDermott from the Beth Israel Deaconess Medical Center, also in Boston, and Dr. Nizar Tanir from the MD Anderson Cancer Center in Houston. This is tonight's agenda. We're going to discuss the current and last up-to-date state of immune and target treatment option in advanced RCC. We have some cases from Everyday's clinic to consider for treatment selection. We're going to talk not just about frontline, but about later line therapies, and then at the end, we're going to offer some insight into the novel modalities that we have on the horizon and the next studies and targets in renal cell cancer. So let me start here. In advanced RCC, we should know our risk. We should know the risk of the patient in front of us. And for that, there are several risk models. Most importantly here, highlighted is the IMDC, the International Metastatic Database Consortium risk model that involve 6 readily available clinical and lab parameters, as you can see. And that captures, to a large extent, the natural history of metastatic RCC patients and divide the patient into favorable, intermediate, and poor risk. And these models are proving to be relevant not just in the targeted therapy era, but also in the more recent era of immunotherapy, as well as combined immunotherapy and checkpoint and TKIs. What do we have today? What do we have today in terms of approved first-line combination therapies? In terms of classes, we have to think about first-line therapy in terms of PD-1 and PD-L1 inhibitors, in terms of TKI, and in terms of CTLA-4 inhibitors. So for poor and intermediate risk, based on Checkmate 214, and Dr. Tanir gonna go through this, we have the combination of ipilimumab, nivolumab. We all call it ipi-nivo. Then in all risk group, 2 combination approved as of today, the combination of pembrolizumab axitinib, pembro-axi, based on Keynote 426, and a 3rd combination of avelumab axitinib, avelumab axi, based on the Javelin Renal 101. If we look at standard of care for advanced RCC for first-line therapy, and we look today at the NCCN guideline, again, the risk group come, and patients are divided into favorable, which is around 20%, 20-25% of all patients, and poor and intermediate. And you can see here the preferred regimen, mostly based on the study being phase 3 and based on the benefit. For example, favorable patient with axitinib pembro or pazopanib or sunitinib, and intermediate and poor patient, nivo-ipi is category 1, axi-pembro, all based on an overall survival benefit. Cabozantinib is there, but it's not category 1 because of the randomized phase 2 of Cabo-Sun. There are other recommended regimen here based on the trial, and then there are some regimen that are useful under certain circumstances. So let's move to look at innovative immune and targeted options. And for that, I'm going to transition to Dr. Tanir Dr. Tanir, please take us here through the immunotherapy option. The floor is yours.
Thank you, Dr. Shweri, and it's a pleasure to be with you and share with you the latest data from the Checkmate 214 study, which is a large phase 3 trial in 1,096 patients with advanced clear cell RCC. This is the study's design. The key eligibility criteria are here: treatment naive, advanced clear cell RCC with Karnofsky score 70% or better. There were 2 strata, IMDC risk, as Tony mentioned, and region. And the patients were randomized 1-to-1 to receive Nivo-Ipi at the standard dose and schedules here, shown here in this box, or sunitinib as the control arm at the standard dose and schedule. The co-primary endpoints were in the patient population with intermediate risk and poor risk, and these were PFS, OS, and ORR. The secondary endpoints were PFS, OS, and ORR in the intent to treat population. That's all patients enrolled on the trial. And there were exploratory endpoints with PFS, OS, and ORR in the cohort with favorable risk. And here is a summary of the median OS and PFS at different time points in this table. These time points are minimum follow-up. The first analysis, the primary analysis, which was published in the New England Journal of Medicine in 2018. Then subsequently, this analysis at 30 months minimum follow-up, and then recently 42 months minimum follow-up, which was published in JITC. And here, as you can see, for patients with intermediate risk, poor risk, treated with Nivo-Ipi, the median OS was not reached versus 26 months median with sunitinib at the initial analysis. And you see the hazard ratio 0.63 for OS, and the tight, narrow confidence intervals. So this was a significant difference. And then just to take you to the latest here at 42 months, which was published, median OS with Nivo-Ipi for intermediate risk poor risk now was 47 months versus 26 months. Again, to just show you over time, the median OS for patients treated with sunitinib has not changed, and now it's about 4 years median OS with Nivo-Ipi for that intermediate risk and poor risk population. Looking at the PFS here, the median was 11.6 in the early analysis versus 8.4 months with sunitinib, and as you go down the line, the numbers have not changed. Just important to mention that for the 30-month minimum follow-up, the assessment for PFS and ORR was done by investigators, whereas at the initial analysis and the more recent analysis, the assessment was done by independent radiology review. Now let's look at the latest data, which was presented at ESMO this last weekend. And here is the Kaplan-Meier curves plot for OS with a minimum follow-up of 48 months for, again, the primary patient population of intermediate risk, poor risk. And you can see here now the median OS for Nivo-Ipi treated patients with intermediate risk, poor risk is 48 months, and for sunitinib, 26 months. The hazard ratio for that difference in OS between the two groups is 0.65 with a narrow intervals, and this was a statistically significant difference. Now next, we'll look at the Kaplan-Meier curves plot for PFS, again, the latest from ESMO with 48 months minimum follow-up for that primary population of intermediate risk, poor risk. The median is 11.2 months for Nivo-Ipi versus 8.3 months for sunitinib. This difference has a hazard ratio of 0.74. And you can see here there is an apparent trend at plateau or tail at the end of the curve for the Nivo-Ipi treated patients. But we'll see over time now with longer follow-up where that tail at the end of the curve will settle. Now looking here at the responses, and again looking at in the first column, the primary patient population of intermediate risk, poor risk. Then in the middle column, the intent to treat, all patients enrolled on the trial, and then the exploratory group with favorable risk. I think it's important to note that the response rate for the intermediate risk and poor risk was 42% with nivo-ipi versus 27% with sunitinib. And this data is basically hasn't changed much from the initial analysis, which was in 2017, and the data has for the intermediate, intent to treat patient population, the response rate is 39% with nivo-ipi for the intent to treat versus 32% for sunitinib. Looking at now favorable risk, this was an exploratory 249 patients with 125 patients randomized to nivo-ipi with favorable risk versus 124 randomized to sunitinib. The results are in favor of sunitinib with 52% of patients achieving a response with sunitinib versus 30% achieving response with nivo-ipi. However, when you look down at the CR rate, and here is the CR for intermediate risk, poor risk, the intent to treat, and favorable risk, you could see that the CR rate here is above 10% regardless of the risk category. And if you look again here at the ongoing responses, despite the fact that patients with favorable risk had a better outcome or superior response rate and longer PFS with sunitinib, yet the patients treated with nivo-ipi, there were a higher percentage of patients with ongoing responses with nivo-ipi. Now, looking at patients who achieved those CRs of 10 plus, 10, 12% CRs, looking at those patients with complete response and looking at what we refer to as the swimmer's plot for those patients. So there were 43 patients treated with nivo-ipi who achieved a complete response with nivo-ipi. And there are three distinct groups here. Those who achieved complete response but are still on therapy, those were 18 patients. And this cohort here of patients who achieved a response and did not receive any further therapy other than nivo-ipi. So they were off treatment and still in CR. And then there is the group that achieved a complete response but subsequently received subsequent systemic therapy. So 19 patients out of the 43, so 44% of patients who achieved complete response did not require any further therapy other than nivo-ipi and maintenance nivo in those patients. And here is basically the same data. 16 patients achieved CR with nivo-ipi who had favorable risk. And again, here there is a cohort of patients, 9 of those 16, who achieved CR and never required any further therapy other than treatment on trial. Now, what about treatment-related adverse events? This bar graph shows you over time the percent of patients who had either grade 1 or 2, and this is presented in the light blue for nivo-ipi, or dark blue is the grade 3 and 4, and in light orange or dark orange, patients treated with sunitinib. As you can see here, the first 6 months are this is the time period where the most of the AEs occurred. So over time, for both treatment arms, the events are decreased over time. The new events are decreased over time. Now, it's important to remember that in the Checkmate 214, 22% of patients discontinued nivo-ipi because of toxicity. And it is also important to note that 35% of those patients who developed immune-related toxicity secondary to nivo-ipi required corticosteroids equivalent to 40 milligrams per day of prednisone. But only 10% required to take the high-dose corticosteroids over a month period. So the question people ask, what would be the outcome? What was the outcome of patients who discontinued nivo-ipi because of toxicity? And some of them, as I just mentioned, required corticosteroids. Well, here is an analysis, subgroup analysis from Checkmate 214 that we published in the Journal of Immunotherapy for Cancer, where we looked at the patients, the cohort who discontinued therapy because of toxicity, and patients who did not discontinue therapy because of toxicity. And you see here the Kaplan markers for OS for these two groups On top are patients who discontinued therapy because of toxicity. And in the blue line, the curve is for patients who did not discontinue therapy because of treatment-related adverse events. And you can say that patients who discontinued therapy with nivo-ipi because of toxicity, their survival was not jeopardized, was not compromised as a result of stopping therapy. So I think that's an important point to keep in mind as a take-home message from the Checkmate 214 data. Thank you, Tony.
Thank you, Dr. Tannir. This is wonderful. Thank you for guiding us through this. And for that, I'm going to switch to hearing the latest about that, because we have a lot of update this year with no one else than my close colleague, Dr. McDermott. David, can you guide us through some of these recent results, please?
Sure, Tony. It's great to be here with you and Dr. Tannir and talk about where we are with the combination of the old first-line therapy, which is VEGF blockade, and the second-line approach, the old second-line therapy, which is PD-1 blockade. So when we think about VEGF blockade and PD-1 blockade, there are several advantages to this approach. You're essentially targeting the two of the driving biologies of this disease, VEGF overexpression, which leads to angiogenesis, and PD-L1 expression, which leads to immune evasion. So by combining PD-1 and VEGF blockade, you're targeting both of those mechanisms that drive the tumor. And that probably is leading to the improved outcomes that we see with patients. By bringing PD-1 up into the front line, you're preventing the death of the patients who have very aggressive tumors that are driven by PD-L1 expression often. And then you are seeing some synergy between these two approaches by combining VEGF and PD-1 blockade. The most impressive data so far in this combination approach comes from the Keynote 426 study, which looked at pembrolizumab and axitinib versus the old standard of care, sunitinib. You see here the eligibility criteria and stratification. All IMDC risk groups were involved in equal amounts. And looking at the combination of PD-1 VEGF versus sunitinib. At the first interim analysis, the results were ridiculously good, with a hazard ratio of 0.53 for overall survival, 0.69 for progression-free survival, and an overall response rate of close to 60%. Over time, those results have held up. This is a look at overall response in an update that was presented at ASCO by Betsy Plimick. Looking at the difference between those survival curves, still favoring the combination of pembro-axi with a minimum follow-up of 23 months. Also, progression-free survival still in favor of the combination. Many of the benefits that you see with molecularly targeted therapy approaches like VEGF blockade happen early in the course of disease, so it's not surprising you see encouraging improvements in median progression-free survival, and these still seem to be maintained out at 2 years. And as I mentioned before, responses are often, very high with these combination regimens, close to 60% with many of them. And you're also seeing complete responses as well, which suggests there's some synergy, meaning in some patients, VEGF blockade is probably enhancing the immune response to the tumor, and hopefully that will lead to long-term durable responses, potentially even after treatment stopped. But we've yet to prove that with the VEGF PD-1 approach. You see many of the responses here now durable at a median of 2 years. Another trial which had many similarities with the Keynote 426 study is the Javelin Renal 101 study, looking at, in this case, axitinib again, but this time with a PD-L1 antibody, avelumab versus the old standard of care, sunitinib. One important difference here with that other study is the co-primary endpoints, once again, were PFS and overall survival, but in the PD-L1 positive set of patients. And not surprisingly, looking at PFS, once again, a clear win for the combination of avelumab and axitinib over sunitinib. However, so far, we have not seen a clear overall survival advantage, although those data are immature. So we look forward to seeing that in future updates. And again, the VEGF addition to PD-1 is driving very high response rates, 56% overall, with almost 6% complete responses. Many of those are durable. Most recently, Dr. Choueiri presented at the ESMO meeting the results of the CheckMate 9ER study. This study had a very similar design to the last two, looking at the PD-1 antibody nivolumab with the VEGF c-MET AXL inhibitor cabozantinib in patients with advanced RCC. Once again, all IMDC risk groups here. And the primary endpoint was progression-free survival in the intent to treat population. Interestingly, while nivolumab was given every 2 weeks at the standard dose, the cabozantinib dose was reduced from the full dose of 60 milligrams to 40 milligrams daily in all patients to start. And once again, a very impressive progression-free survival curve here, looking at Nivo and Cabo clearly beating, almost doubling PFS, excellent hazard ratio of 0.51 over sunitinib, and overall survival also favoring the combination with a hazard ratio of 0.6. Finally, high response rates, 56% with the combination, 8% complete responses. Once again, this data is somewhat immature, so we look forward to more data on durable overall survival and duration of response, but the early data looks very encouraging for both of those endpoints.
Yeah, thank you so much, Dr. McDermott and Dr. Tanier. So let me summarize, both approaches, IO and IO-VEGF, like we say, and mention the clinical take-home messages here. So what can you achieve frontline dual checkpoint blockade versus checkpoint inhibitor and TKI? What are the pro and what are the cons? With dual checkpoint blockade, some of the pros are improved overall survival. We do have with Nivo-Ipi really a mature follow-up data. The responses tend to be very durable, and there's a potential to stop therapy. And let's not forget, yes, it's IO, but after 3 months, we're done with ipilimumab and transfer to nivolumab maintenance. And even in these patients that had treatment-related adverse event, we didn't see a difference in outcome in terms of survival. Some of the cons is there is no doubt there's a higher immune-related adverse event. And compared to TKI plus checkpoint inhibitor, there's a lower PFS response rate, and I would say higher chance of having PD, progressive disease, as best response. On the other hand, with checkpoint and TKI, we're seeing with pembrolizumab improved the overall survival, same as with Cabo-Nivo now. Higher response rate, longer PFS, no doubt, compared to the dual checkpoint blockade, with lower immune-related adverse event as we are using one checkpoint blocker. In terms of cons, what I see is in an imperfect word of AE attribution, I think this comes up, and it is somewhat unclear sometimes how to attribute the side effects and the toxicity. Think about diarrhea that could happen with axitinib, could happen with cabozantinib, but also could happen with immune checkpoint blockers. We all agree that the checkpoint inhibitor and TKI have less mature follow-up, and with 2 drugs on board and with the TKI on board, there will be a chronic TKI toxicity that we don't see with IO, bringing us more into looking at quality of life and patient-reported outcome here. So it's looked like we have some questions coming in from the audience. So hopefully the 3 of us, David, Nizar, and myself, can answer it. One of the question is, what effect, and I was just touching base on that, what effect on quality of life do the different frontline regimen invoke? Just as a summary, this was published with IO Checkmate 214, knowing there are difference in the quality of life questionnaire. The combo of nivo-ipi was shown to be superior to sunitinib in terms of quality of life. Same thing with Checkmate 9ER that Dr. McDermott presented. Also in 2 questionnaires seems to be superior, statistically significant. We didn't see that with Keynote 426. I don't know, maybe I'll ask Nizar here. How do you look at quality of life here, and what do you think based on what we presented and what was presented? Nizar?
Tony, yeah, I think, obviously quality of life is important for patients. I mean, obviously, number one goal for any therapy of a patient with cancer, kidney cancer or otherwise, is cure. Patients want to be cured, and we, treating physicians and researchers, want to cure our patients. And that's the ultimate goal. That's the number one goal. But I think it's also important to consider that to achieve this goal, even if we don't achieve it, except for a small percentage of patients, prolongation of survival and having a good quality of life is important. So I think when you look at, for example, nivo-ipi, I think as I showed the bar graph for the treatment-related adverse events over time, most of the adverse events occur early on, the first 6 months. So I think if a patient is able to go through the induction period with nivo-ipi during the first 12 weeks when they are receiving the dual agents every 3 weeks during the first 12 weeks, if they're able to go through those for 12 weeks, and this actually happened during when we conducted the Checkmate 214 phase 3 trial, and in real world, in practice, our goal is to get our patients through the first 12 weeks. If they get through the 12 weeks and they do not develop any immune-related adverse events, then they go on. It's like going through an easier period with maintenance with nivolumab every 4 weeks. I think there are still some adverse events that could affect quality of life. Patients can develop some of these immune-related adverse events. We haven't spoken much about because of time constraints, but they can develop rashes, arthritis. They can develop immune-related endocrine deficiencies, which obviously can affect quality of life. But the reason the patients on Checkmate 214 treated with nivo-ipi had a better quality of life is because the vast majority of these patients, as we saw, had intermediate risk, poor risk. So they were symptomatic. A good number of those patients were symptomatic from their cancer. So the goal of care, the goal of treatment is to obviously prolong survival when we can and cure when we can. We aspire for that, but we really want to also make those symptoms that the patient is suffering from as a result of their advanced cancer go away or lessen. And I think this is where nivo-ipi, and I would say that also the TKI-IO, the goal there is also to reduce the burden of disease. And by reducing the burden of the disease, even if you do not achieve CR, hopefully the patient's symptoms from the cancer will be lessened. And I think this is a goal
Nizar,
for our care.
You do have, so to you, quality of life and patient-reported outcome are important component when the cure is only in a small small group of patients. Maybe David, directly, the quality of life and the PRO between the 3 studies, 426, 214, and 9ER.
Okay, so comparing across studies is sort of fraught, and I don't think we should do it if we can avoid it. So I don't know that we know that the methodologic differences between the analysis explain the results. I think one thing that might explain some of the positive quality of life results in some of the individual studies is the way the regimens are given. Nizar already mentioned this. In Checkmate 214, nivo-ipi, you're holding the ipi after 3 months. So if you avoid a serious IO toxicity, you're just getting single agent PD-1. That's probably the easiest regimen of these combos to get, is just single agent PD-1. You're avoiding VEGF, you're avoiding CTLA-4. It's hard to beat that from a quality of life perspective as opposed to chronic therapy. In 9ER, you're starting at a lower dose of Cabo, and you're also in some patients reducing the dose. That probably has some positive impacts on quality of life compared to, say, full dose. cabo. But this sort of drives home a second point, which is stopping the drug or stopping both drugs is ideal for quality of life. And we know you can stop nivo-ipi in some patients. Nizar showed that data with treatment-free intervals. We've looked at treatment-free survival. That should be our goal, is creating those deep responders from which you can often stop therapy, giving patients breaks from treatment, creating remissions. That has a major impact on quality of life and length of life. I think it remains to be seen whether VEGF-PD-1 combinations can produce as many treatment-free intervals as we've seen with CTLA-4 PD-1, but I hope so. And those investigators should show us that data. And we should be encouraging, I think in general, future studies to explore stopping therapy in our deep responders, those who have 80, 90, 100% shrinkages of their tumor. Maybe we can stop those patients, give them a break, and improve not only quality of life, but cost and length of life.
Very good. Okay. Let us look at few cases now and focus how we might work with patient to talk through treatment options and perhaps manage safety consideration where on different treatment, one patient of different treatment. So this is Mr. Jones, a newly diagnosed advanced RCC, has several metastatic sites, including liver metastases. Overall, looking at the IMDC risk group, this patient has a poor risk, IMDC poor risk, hemoglobin less than the lower limit of normal, the neutrophil count, the absolute neutrophil count are more than the upper limit of normal. The KPS is 70%, and of course, this patient presented with metastatic disease, so at least 4. So let me ask you, maybe, Dr. Tannir, is this an ideal candidate for dual checkpoint inhibitor?
Yes, Tony, I think this would be the ideal candidate for nivo-ipi, and I've had several of those patients enrolled on CheckMate 214 who had a good outcome and who had actually achieved CR with during the induction. So we didn't do scans till after they finished all 4 cycles of induction with nivo-ipi. So when we did the scans at 12 weeks, they had some of these patients CR. And I think in private, in the real world, in practices, when we treat patients off protocol, these are patients who would be also candidates to receive this therapy. Not to say that a TKI plus a PD-1 antibody, such as pembrolizumab plus axitinib, or as you showed at ESMO, Tony, nivolumab plus cabozantinib, would not be also alternative choices. I think these are alternative choices. When I look at patients with, say, intermediate risk, poor risk, this patient obviously has poor risk. The important thing one has to take into consideration is what is the life expectancy of the patient. If I feel like the patient is able to go through 12 weeks of therapy, or at least 3 cycles of, say, nivo-ipi, and I believe when we do scans, if that patient did not respond, I still have chance to treat that patient with a second-line therapy, nivo-ipi is my first choice. Because then that opens to me all the options for subsequent therapies with TKIs and other options, rather than treating them up front with a TKI plus PD-1.
One thing that comes up all the time is the rate of PD as best response with nivo-ipi when you don't have VEGF inhibition is 20%. Are you worried that this patient may blow through therapy and wouldn't have a chance to control their disease?
So this is exactly what I said, Tony. I think exactly what I said is I do take that into consideration. So obviously what I want to do is give the therapy that would give them the CR that's durable and the tail at the end of the curve, which is what I think is most important for our therapies, is the tail at the end of the curve. Can we cure those patients or at least produce CRs that are durable? But the other important consideration is, do I think the patient has a chance if they progress through the first-line therapy with nivo-ipi? Can I still get them to a second line? If I feel, and this is not science, it's obviously I wish we had predictive biomarkers to know a priori before we start therapy, this patient is going to respond or not going to respond to therapy. And then, of course, we can tailor the therapy to those patients. But if that's where the science clinic, the art of medicine, art of oncology. If I believe the patient has a chance to get to a second line, I would treat this patient. I have treated several of those with Nivo-Ipi up front. And if they didn't respond, I had a chance to go treat them with a TKI such as cabozantinib for a patient like this, for example, in the second line setting.
Let me move, sorry, just for time, to David. You know, in terms of immune, let's say this patient start on nivolumab and ipilimumab. I assume, David, with your vast experience, you've seen at least perhaps, unfortunately, one of these immune-related adverse event. Can you expand on that?
Sure. So when you're applying immune checkpoint blockade in any cancer, including kidney cancer, as far as side effects goes, pretty much anything that ends with an itis can happen. Any organ in the body can be affected, can be inflamed by an immune attack on the organ and lead to complications. Now, the good news is most of those, if detected early, can be treated and reversed with immune suppression, and patients with side effects don't appear to be do worse. That said, you need to know about the side effects to treat them, so that you need to really educate, in some ways over-educate your patients to call. Because if they delay calling for new symptoms like a new skin rash or new diarrhea or worsening fatigue, that can often translate into a bad outcome where they need to be admitted for, say, IV immunosuppression, or they end up in intensive care. But if they call you early, you can intervene and reverse these side effects quickly without making it more likely that the cancer will grow. So education, early intervention are key. There's some of these on this list that are more common than others. So, for example, diarrhea, skin rash, are pretty common. Some are fortunately rare. Some are more reversible than others. But education, early intervention are the key to managing these and safely and effectively.
Great. Thank you, David. Let's move to Mr. Smith, a 52-year-old man present with stage 3 disease. And this patient had a radical nephrectomy, underwent regular surveillance imaging, and at 18 months, this patient had 2 enlarging lung nodule and classified overall as a favorable risk per the IMDC risk criteria. David, back to you. How would you, let's say, given the recent data, what would you do here?
Well, if you're going by the NCCN criteria, PD-1 certainly makes sense, and the favored combination based on the data would be a VEGF PD-1 combination, with so far the strongest data, because you have both PFS and OS with either Nivo-Cabo or Axi-Pembro. They're very comparable data sets in my opinion. So offering that to a patient is certainly the standard. There are those who would also offer Nivo-Ipi in this setting, and I believe it's a therapy that's considered in the NCCN guidelines, but not most favored. You can make an argument that makes sense as well. Overall survival here seems to be the same when you compare Nivo-Ipi in favorable risk to sunitinib, but the time that patients spend off treatment, the number of CRs is higher in this subgroup, so that could also be considered. But I think VEGF PD-1 is the way to go for Mr. Smith.
I agree. I mean, this is, and we talked about toxicities, also with IO TKI, where we withhold TKI, continue IO components sometimes. I think important to, and we forget to do that, to support and give appropriate supportive care. And one of the things is, if the AE does not resolve with TKI cessation, thinking about someone, let's say you started on VEGF IO, and we suspect an immune-related adverse event, to manage the toxicity first as fast as we can, and using the current immune-related adverse event management guidelines. And really, this touch base on what David was saying, how to encourage patients to report adverse event early. This is a beautiful study where they surveyed over 1,100 patients with advanced RCC. And a lot of responders actually reported they often waited until their next appointment to report adverse events. So David, your practice, in line with actually when we talk to the patient, not just when you feel that the patient, wait, but actually this is coming from the patient. This is almost, a patient-reported outcome. But look at the green. 28% of patients wait until the next appointment. And if you add to the patient that maybe do not want to, upset their provider or, never. So you have 38%, more than 1/3 of patients either waiting to the next appointment or never calling, and only 1/3 of patients, immediately calling. So I think we have to do overall better job for education. Now maybe back to Nizar a bit. Let's say Mr. Jones or Smith, both of them develop unfortunately progressive disease in RCC. This is the latest in terms of NCCN option for second-line therapy. Think about it. This is in terms of second line mostly rather than specific for IO. Cabozantinib based on Meteor is category 1 OS benefit. Nivolumab based on Checkmate 025 is category 1. And we've seen nivolumab and ipilimumab, especially post-TKI, having activity. These are the NCCN other recommended regimen. Axitinib is still there based on the ACCESS trial, although that trial was mostly post-TKI or post-interferon, not post-immune checkpoint blocker. And we do have, other potentially useful drugs and combination under certain circumstances, drugs, single agent, like high-dose IL-2. David, in this situation, whether the patient, let's say, was on nivo-ipi or a VEGF IO, what is overall your second-line therapy?
Right, so there is some data, and we'll go over it, but there's not a lot of prospective data on what to do after patients fail combinations. I think, and Nizar alluded to this earlier, when patients are on IO first, it's reasonable to assume that VEGF blockade will work very well in those patients. So when you're going from ipi-nivo to say something like cabo or axi, you're probably going to see activity. So switching to VEGF in those patients makes a lot of sense. It's less clear what works after VEGF PD-1 fails, and we need prospective trials in that setting. Considering an alternative VEGF strategy is certainly rational. So if a patient had axitinib with pembro, going to cabo makes sense. If someone had cabo with nivo up front, switching to axi makes sense. But we need more trials for these patients.
Dr. Tanir, you don't have a trial and the patient, let's say, started by nivo-ipi or VEGF IO. What's your preferred regimen, second line, even without explanation? What jumps to mind?
I think first it's important to, I'd like to make this point, and this is a plea. Patients who receive an immune checkpoint-based therapy in first line and they progress, unless there is a clinical trial for them with another immune checkpoint inhibitor, they should not be receiving another PD-1 antibody in the salvage setting.
Thank you. So let's look at the road ahead, surveying potentially the next wave of innovation. I wanted to go through, phase 3 trial that assessed the immunotherapy combination, starting with Cosmic 313, that will answer a lot of questions because it does use, finally, a modern control arm. The control arm in this study is nivolumab and ipilimumab, and the experimental arm is the combination of nivolumab, ipilimumab plus cabozantinib 40 milligram once a day. This is an ongoing study that is accruing patients as of today. Patients are stratified by the IMDC risk score in the region progression-free survival by independent central review is the primary endpoint, and OS is a key secondary endpoint. Another study is an alliance study here led by Dr. Zhang and others by the name Pedigree. It's a more sequential type study where a patient with intermediate and poor risk, like with Cosmic 313, get nivolumab and ipilimumab, and then it's a response adaptive design where if they have a CR, they get nivolumab for a year, those 10% of patients. If they have PD, they cross to cabozantinib, a single agent. And for those 70% of patients that have, a partial response or a stable disease, these are the patients normally they get nivolumab. Well, that is the maintenance standard here, or the experimental arm becomes nivolumab or cabozantinib. This study is actively enrolling. Pivot 9 is a study that actually Dr. Chenier is leading here. It's a novel drug, epigylated interleukin-2 agonist by the name Nectar-214 in combination with nivolumab versus sunitinib or cabozantinib. Also, the study is actually enrolling worldwide. Now, a study that actually finished enrolling is this CLEAR study. It's quite an interesting study that have sunitinib, hopefully one of the last studies that have sunitinib as control arm, and has two experimental arms. One is the combination of lenvatinib and the PD-1 inhibitor pembrolizumab, and another combination actually that doesn't have an immune checkpoint blocker. It's a combination of lenvatinib and everolimus. The primary endpoint is progression-free survival. So I'm going to transition to Dr. McDermott, since we discussed examples of ongoing approaches for first-line therapy. We touched base on second-line treatment. But what actually happens when PD-1 and PD-L1 inhibitor fail our patients and their tumor progress? David?
Great, thanks, Tony. So there isn't a lot of prospective randomized data in this space, but there is some data. And this was one of the trials that was led from the team at Memorial Sloan Kettering. Dr. Lee has presented this at several meetings, looking at the VEGF inhibitor lenvatinib with PD-1 blockade and pembrolizumab in a phase 2 single-arm trial, looking at patients who had been exposed to either PD-1 or PD-L1 and then progressed. And here you see very encouraging response rates in that setting with the combination close to 58%. The vast majority of these responses were partial responses. The group didn't report any new safety signals, and they're planning a phase 3 trial looking at this, potentially in the future. Another study that's looked at a novel VEGF inhibitor, tivozanib here, which is a very potent VEGF inhibitor with a very clean toxicity profile. This drug is approved for use in Europe, but not yet in the US. This was the trial of patients who had failed multiple prior regimens. Most of them had failed multiple prior VEGF regimens. They were then stratified based on whether they had received a prior TKI with a checkpoint inhibitor or just TKI and something else, comparing head-to-head with the old therapy sorafenib. A clear win here in both progression-free survival, favoring tivozanib, with an encouraging tail on the curve here out at 2 years, almost 20% of patients progression-free, and this is a very VEGF heavily treated patients. So in this trial, these are patients who are not only getting a statistically significant benefit, but probably a clinically meaningful one. It's uncommon to see such durability of response in a heavily pretreated group of patients. Overall survival was comparable in both groups. This trial was alluded to before, so obviously we need prospective randomized trials in the setting of when patients had both failed VEGF and PD-1. On the tivozanib trial, only a small subset of patients had been exposed to PD-1 blockade, and there the activity of tivozanib was encouraging. Let's look at this CONTACT-3 trial, which looks at patients who've had prior immune checkpoint treatment and randomizes them to either the current standard of care, one of those standards, cabozantinib, versus the combination of cabo plus the PD-L1 inhibitor atezolizumab. So this will give us some prospective data so we can answer the question that Nizar was posing before, is does PD-1 or PD-L1 blockade have any role after patients have failed a checkpoint inhibitor? So hopefully this study will give us some of those answers. Also looking at salvage therapy, we would like to give single agent PD-1 blockade alone, if possible, to certain patients because the toxicity profile is so favorable. This was 2 trials that were presented at ASCO this year, Omnivore and the HCRN trial, where patients all started on Nivo, and based on their response, ipilimumab could be added. We saw encouraging toxicity with this sequential approach, but some limited efficacy. It seemed like you were seeing slightly lower response rates when IPI wasn't added right away, and lower CR rates. So delayed IPI may not be as potent as IPI upfront with nivolumab. Now back to Tony and Dr. Chin.
Yeah, what about in totally new drugs and new modalities and, attacking new pathways, something we always get excited about. So I'm going to give it to Dr. Tanir here to start talking, starting with the glutaminase inhibitors. Nizar?
Thank you, Tony, and thank you, David. As we look at the road ahead of us, as we mentioned at the outset, what are on the horizon some of the exciting novel agents? And I'd like to review 2 of those. The first one I'm going to speak about is the glutaminase inhibitor. This is now has a name of telaglenastat. It was CB839. It's first, I think, to really understand how this drug works, I think it's good to review quickly the metabolism, tumor metabolism. So first, a normal cell will utilize glucose and produce energy in the mitochondria through the TCA cycle through glycolysis. But a cancer cell has an abnormal glucose metabolism because of the Warburg effect. So glucose is taken up by the cancer cell, produces lactate, and that's not efficient to produce energy for the cell. So what does the cancer cell do? The cancer cell tries to compensate for that abnormal glucose metabolism by increasing glutamine utilization and glutaminase. So many tumors have increased glutaminase expression in them, and this enzyme converts glutamine to glutamate, and glutamate is taken up in the TCA cycle to produce the energy. In preclinical studies, the combination of this drug, CB839, telaglenastat, which inhibits this glutaminase 1 enzyme that, as I said, blocks the conversion from glutamine to glutamate. So in preclinical studies, the combination of this agent with signal transduction inhibitor, such as everolimus, inhibited both glucose and glutamine metabolic pathways and produced some synergistic anti-proliferative activity in vitro. And it had enhanced anti-tumor activity in mouse xenograft models. Based on this preclinical data, the first trial was launched, and here is the study design of this phase 2 trial. It started as a 252-patient randomized phase 2 trial, but then the design was changed to make it a 2-to-1 randomization, 69-patient trial, where patients with the key eligibility criteria shown here on the slide. So this is a salvage regimen after at least 2 prior lines of therapy, and the stratification, as you see here, by MSKCC risk and prior TKI 1 or more than 1 prior TKI. Patients received the CB839 or telaglenastat at 800 milligram twice daily, plus everolimus 10 milligram a day, versus placebo plus everolimus. So the primary endpoint was PFS by investigator. Again, this is a 2-to-1 randomization, and the results are shown here. They were presented at ESMO 2019. So this is a Kaplan-Markov plot for PFS for the two arms, and you see in yellow is the placebo plus everolimus, the control arm. The curve on top is the telaglenastat plus everolimus. So obviously this is a small phase 2 trial, as I mentioned. So the median PFS was encouraging in that it was 3.8 months with the combination with the telaglenastat versus 1.9 months for the placebo plus everolimus. Responses, however, were low and 0 responders in the everolimus placebo arm versus 1 responder out of 46, 2.2. But the regimen was very well tolerated, and that was encouraging to design the next trial, which is a registration trial that actually received the breakthrough designation and accelerated approval. And so we await the results hopefully by the end of this year. This is the Cantata trial design. This is a 444 patient phase 3 trial, and it's in the salvage setting again, up to 2 lines per hour of therapy, stratification by PD-L1 exposure and IMDC risk. The primary endpoint is PFS by investigator initiated, so by blinded, not investigator, by blinded independent radiology review. The 2 arms of study, the agent telaglenastat 800 milligram twice daily plus cabo at full dose 60 milligram per day versus placebo plus cabozantinib. So as I mentioned, the results hopefully will be available by the end of the year. And if this is a positive study, hopefully this will be a novel agent that will make it to the clinic for our patients. So the next exciting agent is the HIF2 alpha inhibitor, MK6482. And I think it's important here to review quickly that patients with sporadic clear cell RCC have defective VHL protein that leads to constitutive accumulation of HIF, and the important HIF here that does the damage in RCC is the HIF2 alpha. And this agent is a small potent molecule that blocks the HIF2 alpha, and it took years of understanding the biology of clear cell RCC, the work of Dr. Bill Kaelin, who received the Nobel Prize last year with his colleagues on understanding hypoxia and HIF. And this is the fruit of this decades of research that brought us this exciting small molecule HIF2 alpha inhibitor to block HIF2 alpha. And the study that I'm going to review here quickly in one slide was presented at ASCO GU last February by Dr. Shweri. Here is the summary of the efficacy endpoints. So first of all, this agent is tolerable. There were few adverse events, anemia because it blocks EPO, and a few patients, 4%, I believe, had hypoxia, again, because of the mechanism of action. But the impressive thing is in this box here, that this is a waterfall plot showing a tumor regression. These are heavily pretreated patients, and you see that the response rate in this heavily pretreated patients, there were 55 patients enrolled on the study, 24% objective response rate, and a PFS median of 11 months. There were responses in all IMDC risk categories, favorable, intermediate, and poor risk. Because of its favorable safety profile and the encouraging results in this heavily pretreated phase 2 trial, there is now a large phase 3 trial, registration trial, with this agent versus everolimus. This is a 736 patient phase 3 trial randomizing MK6482 at the dose 120 milligram orally daily versus everolimus at the standard dose and schedule. In these patients, the stratification is by AMDC, a number of prior VEGF agents, 1 versus 2 or more. Here are the key eligibility criteria, similar to what we've seen before, but basically up to a maximum of 3 3 prior lines of therapy. The endpoints, the 2 co-primary endpoints are PFS and OS, and I think the trial has launched, has been accruing. This is a global study. I think if it's positive, I think it will be welcome news for our patients with RCC because it brings them also a new class of agents that could be potentially combined with immune checkpoint inhibitors or mTOR inhibitors or even TKIs to actually increase the potential of responses. Back to you, Tony.
Oh, thank you, Dr. Tanier. So let's check in with our viewers. I see a few more questions. Maybe Dr. McDermott here. Are you using nivolumab and ipilimumab in favor risk patient? And do you see a situation where you can do that?
Yes, we do that. We obviously have a long discussion with patients before we do that. Right now, the NCCN guidelines don't give it its strongest recommendation, but there are patients who are very motivated to achieve not just long-term overall survival, but gain a chance at treatment-free intervals and treatment-free survival, and we think Ipi/Nivo offers the best chance of that. So if the patient is relatively young and motivated, understands the risks of the side effects, and is willing to accept those trade-offs, we move forward with Ipi/Nivo in good risk patients.
Thank you, thank you. And a question for you, since you've been involved, with your leadership in biomarkers in renal cell cancer. Today, we do not have one approved to help us in metastatic or even early stage RCC. But what do you think we should do?
Well, I think we're doing better, but it's not going to be easy. Single agent biomarkers are hard, particularly in a disease as heterogeneous as as kidney cancer. Combination biomarkers are going to even be more difficult, but we are making some progress with, for example, RNA sequencing. As you know, there seem to be gene signatures that are associated with response to both VEGF blockade and immune therapies, and so we should be including those looks in our prospective trials because there may be ways, for example, to select patients who are considering pure IO approaches or certainly second line pure VEGF.
And we're all working together as a community, all of us, which really is very refreshing for patients. That's what patients want us. So in summary for this program, I hope first you enjoyed it. I hope now you are familiar more, especially with the latest update up to just last week, ESMO 2020. You're familiar with new approaches in first line and putting it in context with the focus of on VEGF IO and IO. Of course, that creates a conundrum with second line with post IO treatment, and hopefully overall you've seen also some of the potential art of medicine that we have to really practice with all these side effects, especially the immune related adverse event. Thank you very much for your attention.
This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GKC860.